We're going to move on to our next question, our next patient. A 39-year-old woman who works as the coordinator for HIV programs in Brooklyn, New York, was in her usual state of health until she lost consciousness while sitting in a restaurant eating lunch with her friends. Okay, so right now, all I know is that this is a loss of consciousness question. The boards ain't going to give you a big frame that says, next question, headache. Okay? All I know so far, she's at a loss of consciousness. I'll go down to scan to the bottom, and it'll say things like CAT scan or MRI, things like that. Or maybe they'll ask me different medications like sumatriptan or beta blockers or ergotamine. Sounds like headache medication. All right? So that would tip me off that this is going to be not just a loss of consciousness, but a headache question. But again, I don't get that much information from the first sentence. Put me on pause. Read the rest of this, what's left of this brief history. And again, 39-year-old woman, works in Brooklyn, usual state of health, sudden loss of consciousness. She awoke spontaneously in the ambulance 10 minutes later, and as she arrived in the emergency room, she complained of a severe headache. She also complained of nausea and photophobia. All right, so right now, if there's a single best answer question, I got a pretty broad differential in my head. I don't know what she has. She's had a loss of consciousness, sudden loss of consciousness. Sounds like she's been previously healthy. I didn't get any past medical history so far. And then she awoke with a headache. Now, why did she have a headache and a loss of consciousness? Well, the loss of consciousness came first. She woke up with a headache. I don't have a good connection for that yet. All right? Certainly, headache in association with loss of consciousness, I could think of some bad things that cause headaches. And those are starting to occur to me now. What's a bad thing that causes a bad headache and a loss of consciousness? Subarachnoid hemorrhage. Maybe an intraparenchymal bleed. If she had a loss of consciousness after a seizure, can she wake up with a headache? Yeah, people wake up from seizures very often have headaches. But most people who have loss of consciousness after a seizure, it's after a grand mal seizure. She didn't have a secret grand mal seizure sitting at lunch with her friends in Brooklyn. People in Brooklyn might not be that bright, but if someone's having a grand mal seizure in front of them, they'll usually recognize that something's wrong. They'll say, oh, she looks a little chilly today. She's shaking a little bit. All right? We don't hear that in this question. I don't want to get letters from Brooklyn because I grew up in Brooklyn. All right? So I get the right to rag on Brooklyn. Physical exam, vital signs. Febrile, sort of tachycardic, definitely hypertensive, respiratory rate of 16. Well, just by virtue of the loss of consciousness, this is going to be sort of an acute emergent problem. Doesn't mean I have to give the patient a medication right away, but I'm going to have to act pretty quickly in this patient. How about the rest of the physical? Head and neck exam, photophobia. Fundoscopic examination is normal. How's a fundoscopic examination normal help me? Tells me that the optic discs are flat. I mean, that's what's included in that description, even if they don't say it verbatim. That means there's no increased intracranial pressure. So brain mass causing a loss of consciousness, less likely. Intraparenchymal bleed, that's from increased pressure. That pressure would probably still be there. Might have some papilledema. I don't see that here. Nuchal rigidity is present. Could this all be meningitis? Nuchal rigidity, meningeal irritation. I know a patient with very severe meningitis can have a loss of consciousness. Has a fever. Meningitis should be on my list. What's a little atypical for meningitis here? Sudden loss of consciousness. Patients with bacterial meningitis don't sit there and all of a sudden go out from bacterial meningitis. So usually they've been sick, fevers, some other evidence of a upper respiratory tract infection or some systemic infection, and then they have signs of an infection, fevers, etc., and then they'll get progressively more obtunded. They don't have that sudden loss of consciousness. So it doesn't quite fit. But at least I'm going to think about it with the fever, change in mental status and nuchal rigidity with photophobia. Chest is clear, there's no heart murmur, abdomen is benign. Neuro, she's now alert and she has no focal deficits. Makes the intraparenchymal bleed a little less likely because there might still be a pressure phenomenon there. Makes brain tumor less likely because I would expect the mass effect, papilledema, other focal deficits. Subarachnoid hemorrhage. Can you have a big bleed, stop the bleed, have a headache, have a non-focal neuro exam? Sure. Okay. Usually the patient will have the headache, might get worse to the point that they lose consciousness, it's not because the headache is so severe that they have a vagal episode. It's because there's been a subarachnoid bleed and there is so much pressure that there's obstruction to outflow and the patient has high intracerebral pressures to the point of losing consciousness. All right? Gradually there's some drainage of that pressure, and although there's still meningeal irritation giving you the nuchal rigidity, there's no papilledema as that pressure is reduced. And that's how the patient was able to wake up on her own. So subarachnoid hemorrhage is right now at the top of my list for these reasons. Intraparenchymal bleeding, well, I'd like to see that she has either a bleeding disorder, that there's been some head trauma, that there's been something there that should make her bleed. Probably the most common reason for intraparenchymal bleed, poorly controlled hypertension. Now, she does have hypertension. And hypertension can be an underlying fact to provoke someone to have a subarachnoid hemorrhage as well as intraparenchymal bleed. But again, the acute event with the recovery without any focal deficits makes intraparenchymal bleeding a little less likely, although not impossible. Meningitis, very atypical in terms of the very acute presentation with the initial symptom being loss of consciousness. Migraine headache, well, there's an interesting one. Migraine headache. Do I get a fever, 38.7? A little high. Most migraines don't have fever at all. If they do, it would be low grade. A little tachycardia, hypertension with migraine? Not necessarily. Are they photophobic? Yeah. Normal fundoscopic exam? Yeah. Nuchal rigidity? No. So migraine is very unlikely, especially in light of the loss of consciousness. Patients with migraine might feel so terrible they wish they were unconscious, but they don't lose consciousness. Lastly, vertebral basilar insufficiency, usually not in this age group. Usually patients have signs of cerebellar dysfunction. They can have a loss of consciousness. But again, I don't hear any history of ataxia or anything preceding this sudden loss of consciousness to make me think of vertebral basilar insufficiency. So right now, my leading diagnosis would be subarachnoid hemorrhage. Unlike some of the previous cases we discussed where I was very cocky, very sure I knew the diagnosis, can I be quite as sure in this patient? The answer is not quite so sure. What would be my diagnostic test I would do here? This would work very well for a CCS question or a single best answer. What would you do next in this patient? Would I tap the patient? In other words, do a lumbar puncture? Well, she had a loss of consciousness. She doesn't have focal deficit, so I don't think that she has a mass lesion, but certainly I have to think about that. Now, doesn't she work in an HIV clinic? Maybe she has HIV. Do we have any clues that she has HIV? No. But they brought that, maybe she works in an HIV clinic because she has HIV and she's trying to help. Doesn't sound like HIV. Can HIV give you loss of consciousness and seizures? Are there such lesions? Yes. Loss of consciousness is usually with a mass lesion, usually toxoplasmosis. Okay? Seizures could be with a mass lesion. Again, toxoplasmosis. Meningitis in HIV. Usually cryptococcal, all right? And we have some meningeal signs here. But again, it doesn't quite fit. There's a profound change in level of consciousness to the point of loss of consciousness. And intraparenchymal bleeding and subarachnoid hemorrhage are my two leading diagnoses. I want to get a CAT scan or an MRI. A CAT scan here, even without contrast, will be very sufficient. Non-contrast head CT, what does it show me? It's normal. Does that rule out the presence of a subarachnoid hemorrhage? Say it's a small subarachnoid hemorrhage in the first few hours, not big enough, maybe big enough to cause loss of consciousness, but not big enough to show up on a CT. Can that happen? Is a non-contrast head CT 100% sensitive? No. Now I would proceed with the lumbar puncture. I would not have done a lumbar puncture first, because in the small chance there's a small mass lesion that I'm not picking up by papilledema or by finding a focal neurologic finding, but that there's still increased CNS pressure, I'm not in a hurry to do a spinal tap in this patient, in whom meningitis is a low suspicion, until I'm sure that there's no mass lesion in there. Now I'm sure there's no mass lesion in there. Now I want to do a lumbar puncture. What will I look for in this lumbar puncture? Well, if it's a subarachnoid hemorrhage, I will find lots of red blood cells. And here I find 17,000 white blood cells, 45% lymph, 50% polys. But you know what that represents? It probably just represents regular blood floating around in the patient's head that ruptured and now is in the CSF. So I'm not worried about this number of polys. This is just representative of the patient's generalized blood flow, because what I look at is there's 11,400 red blood cells. Now, red blood cells in themselves, you might say, well, can't that be a traumatic tap, that you hit a blood vessel on the way into the spinal column? The answer is yes, that can have happened, but you're told here specifically that there's xanthochromia. What is xanthochromia? After several hours of blood sitting in the CSF, the red blood cells start to break down and produces a yellowish discoloration, which you'll see just by tapping the patient, holding it up to the light, and you'll see that it's yellow discoloration. That's xanthochromia. And that will help you distinguish between a bloody tap, which is from a subarachnoid hemorrhage, in which the blood has been in the CSF several hours and produces that yellow discoloration, versus a traumatic tap where your needle just caused some blood cells to enter your CSF and there is no xanthochromia. Right? So xanthochromia is very suggestive that that blood has been there for a while and that therefore this patient has a subarachnoid hemorrhage. Okay, so subarachnoid hemorrhage. What would I like to see in the question to make it very obvious? Patients will typically say the words, "This is the worst headache of my life." Now you all say everybody has a worst headache of their life. If you've had 2 headaches in your life, one of them was the worst one. But what patients will truly tell you, this was something very different. All right? It has a sudden onset, and this patient actually presented with a loss of consciousness because of the increased pressure from that transient bleed. Because it bleeds and gets into the CSF, there's meningeal irritation, and that's why this patient will have the nuchal rigidity that she had. There's alteration in mental status, which is, again, due to the bleed and the transient increase in intracranial pressure. And usually, what's the underlying lesion? It's a congenital berry aneurysm in the circle of Willis. Now, as an aside, what other clues might you have by this patient's history or a family history that this patient might have berry aneurysms? What are the associated conditions with berry aneurysms? Let's say I tell you the patient has a sister who's hypertensive and required dialysis, and when they took out one of her kidneys at transplant, they found out she had a giant kidney. Or she had a CAT scan once, and she was told she has cysts in the liver and cysts in the kidney. Polycystic kidney disease. Many of those patients have associated cysts in other organs, such as the liver, and about 10% of patients with polycystic kidney disease, which is an autosomal dominant disease and not rare, about 10% of adult polycystic kidney disease patients will have berry aneurysm. So when a patient who I have who has polycystic kidney in the question, then let's say it's well controlled. Let's say they don't have hematuria, they don't have the hypertension you see with polycystic kidney, but now they have a big, big headache. I'm going to worry that that might be a subarachnoid hemorrhage from an unknown, previously unknown berry aneurysm. So the diagnosis, you got to maintain a high index of clinical suspicion. All right? A lot of people who don't need CTs and spinal taps should be getting CTs and spinal taps because they say it's the worst headache of my life. And you're always going to have the worst headache of your life at some point. A lot of those patients should get CTs because, again, this is fortunately not as common as a bad tension headache or a bad migraine headache. That's the worst of your life. But it's, again, something you can't afford to miss. You'll start with the non-contrast CT, which is quite sensitive, but not 100% sensitive at picking up a subarachnoid hemorrhage. And then you're going to proceed to do your lumbar puncture, where you'll look for red blood cells, and you'll also see xanthochromia. The treatment. Let's say the question on CCS makes it clear that the patient has a subarachnoid hemorrhage. Either they give it to you in the question stem, which in CCS is unlikely, but on CCS you'll say, this patient sounds like they have a subarachnoid hemorrhage. Let me get a CAT scan. They say there seems to be a subarachnoid hemorrhage based upon the CAT scan results. Or you say, CAT scan is normal, I'm still concerned on CCS, this patient might have a subarachnoid hemorrhage, and you go ahead with the lumbar puncture, you see the red blood cells, you see the xanthochromia. There's still 15 minutes left. The computer at the exam is not telling you, thank you for taking care of this patient, you've got to do more stuff. Well, what do? Well, you're going to address the blood pressure. You don't want the blood pressure to fall too low because if you do that, you might decrease cerebral perfusion and the patient might have a stroke. Or the patient might lose consciousness from hypotension. But on the other hand, you don't want to sustain a very big blood pressure in the cerebral perfusion. you don't want additional subarachnoid hemorrhage to happen. So you want to control blood pressure in sort of the upper range of normal. I'm not looking to give this patient a blood pressure of 110 over 60. If they're 140 over 90, 150 over 100, I'm happy with that. On the other hand, the reason they had this subarachnoid hemorrhage, we said one of the reasons is hypertension. If they're 220 over 120, I got to do something about that. We're going to want to do an angiography once this episode is controlled in the ways we're discussing now, early, because again, this patient just ruptured a barrianeurysm. This patient is at risk for recurrent subarachnoid hemorrhages, and the next one might be the last and fatal one. So you'll do an angiography early on. If the patient does not have what looks like on angiography a continuing leak from a barrianeurysm, one drug that I would consider using, and this is to address the possibility of vasospasm, which often follows the original subarachnoid hemorrhage. The original insult is the bleed, and as a compensatory mechanism, the cerebral blood vessels vasoconstrict, and they can vasoconstrict to the point of hypoperfusion. A drug in the calcium channel blocker, the same family as nifedipine, called nimodipine, is useful in this situation to prevent vasospasm. Again, what do you need to be concerned about is that you don't lower the blood pressure too far with this calcium channel blocker. And once the patient is stabilized, or if the patient doesn't stabilize, you're going to need to consider doing a surgical clipping of that ruptured barrianeurysm. So, in summary, subarachnoid hemorrhage, fortunately in real life you don't see too many of them, but on the boards you'll see them disproportionately because it's, again, something you can't afford to miss. The initial management is to control blood pressure, but not to lower it too much, because you can have an infarction from insufficient pressure. Later, in other words, after those first few hours you're managing the patient in the ER, what you're worried about is infarction, if you let the blood pressure go too low, rebleeding, if you haven't identified and clipped the barrianeurysm, or if you let the patient's blood pressure sit too high, you're worried about rebleeding. And lastly, if there's a big bleed in the first place or with a recurrent bleed, you can get outflow obstruction and end up with a hydrocephalus. You're unlikely to be tested on the complications of the subarachnoid hemorrhage. You're more likely to be tested on the initial recognition, diagnostic tests, and management of that patient with a subarachnoid hemorrhage. Okay, that wraps up that question. A good question for both CCS and for a number of single best answer questions. And we're going to move on. And again, in the real life, they don't tell you that the next question is going to be a headache on the boards. Patient's a 20-year-old woman with a severe headache. Okay, I'm going to jump down to the bottom of the question, see if it's a single best question, single best answer, see what the choices are, and then put me on pause and read the rest of the question. Then hit play. Play me. She describes a headache history that began when she was 14 years old. Headaches occur every 3 months and are very severe. All right, so this sounds like a chronic problem. Yeah, it's a severe headache, but she's having headaches for 6 years. She describes an alteration in vision that begins in the right field of vision and consists of bright flashing lights. She has, well, what does that make me think of right there? Chronic headaches, young woman, flashing lights preceding the headache. Already, I'm fairly certain I have a definitive diagnosis in this patient, and that is migraine. And more specifically than migraine, what kind of migraine? Classic migraine. She has just finished a very challenging year in college. Now, coming home to her parents' house, she noted the recurrence of this headache accompanied by both visual symptoms as well as by nausea and vomiting. Now, is that consistent or inconsistent with migraine? Entirely consistent. It hasn't made me change my mind. This headache is much worse than her previous headaches, and she has decided to get medical evaluation. Now, it's much worse. Can this be a woman who has chronic migraines, even classic migraines, and now has a subarachnoid hemorrhage? The answer is sure. She has recently started birth control pills and is taking up smoking tobacco. She's a wild woman. Physical exam. Heart rate, 92. Blood pressure looks okay. Respiratory rate, okay. She's afebrile. Has that helped me? No, it doesn't sound terribly acute. It doesn't push me in the direction of an acute subarachnoid hemorrhage. Neurologic exam, non-focal. Brain tumor and AVM are not suggested by this neurologic exam. Differential diagnosis. Okay, classic migraine. We just discussed that. We'll talk in more detail in a few moments about what migraines feel like, look like, how we distinguish them. Common migraine is basically the migraine without the prodromal visual or other sensory findings. Can she have had a seizure and woken up with the worst headache of her life? Again, we discussed that with subarachnoid hemorrhage. There's no history seizure here. There's nothing witnessed of seizures. She's had 6 years of symptoms. There's nothing about this headache other than its severity that sounds that much different. I don't think this seizure, that seizure is really a very likely diagnosis. Similarly, brain tumor, there's nothing here in terms of focal deficits, papilledema, anything to suggest increased CNS pressures. And an arterial malformation, while it can present with bleeding and a loss of consciousness in much the same way that a subarachnoid hemorrhage from a berry aneurysm, is again unlikely to have this sort of chronicity to it. So this is basically a straightforward question. It makes a good single best answer, and also can now be used as a jumping point. Yeah, you made the diagnosis fairly easily by the history and basically a negative or normal physical. How are you going to manage this patient? What are the different steps of management in migraine? Well, first of all, is there anything else I need to consider in the evaluation of this patient, who I think pretty strongly, my degree of confidence that she has a classic migraine is pretty high. Should I treat her empirically, or do you think it's reasonable to do some tests to make sure that this headache, which after all is worse, deserves some imaging? Well, I think it's reasonable to get an MRI. If in this particular patient on CCS you went straight to management, I don't think you'd lose much. An MRI here, on the other hand, I don't think you'd gain that much, but again, you want to rule out other possibilities. The MRI in her case, as in patients with migraine, is basically being done to rule out other likelihoods. Migraine per se will not cause any abnormalities in the MRI. What else might I consider in this patient? Anything else besides that short differential? I can't think of anything. Tension headaches. Well, tension headaches. That could definitely be the differential. History and physical. Well, oral contraceptives, smoking, maybe that is more likely to trigger migraine. Can the chronicity distinguish between migraine and tension headaches? Not really. Can an MRI distinguish between migraine and tension headaches? Not really. Let's look back to the initial description. What is the one finding here on this slide that does clearly distinguish migraine from tension headache? Is it her age? No. Is it the chronicity? No. Is it the occurrence every 3 months and its severity? No. Is it the change in vision? Yes. All right. That is unique to migraine headaches compared to tension headaches. We've done the MRI, confirms that there's nothing else going on. What are the clinical features that we've just discussed that suggest migraine? Often unilateral, often a pulsating or throbbing quality, as opposed to tension headache, which we'll mention in a moment, has more of a constricting quality, like someone tied a belt very tight around your forehead, whereas migraine tends to be more in one region, although it can be bilateral, usually more in the front, and it's a pulsating type of quality. Nausea and vomiting, photophobia are common. A lot of patients who have had migraine, the second they get that aura, A-U-R-A, the aura is those visual symptoms they get, they know the migraine is coming. The aura happens sometime, not days, but minutes or even an hour or two before the migraine. They know the migraine is coming. The aura itself is a warning signal. It's not painful. These patients know that they're going to have a fierce headache. They'll do what we know to be the right things to do in terms of aborting the attack, but they're going to head for their bedroom and pull the shades, shut the music off, get under the covers, and pray that they could fall asleep. All right? A dark, quiet room is relaxing to someone with a migraine. Any sort of sensory stimulation is going to exacerbate that headache. Bright lights will exacerbate that headache. What are triggers? For someone who has a known history of migraine, what's more likely to provoke them? Women in their menstrual cycle, when they're approaching their menses, are more likely. Oral contraceptives, and even an increase in oral contraceptives. If a young woman comes to you with a new onset of headache or a worsening of a chronic headache, and they put in that history very clearly that she has just started oral contraceptive, or she has changed the dose of her oral contraceptive, the first order of business will be to either reduce the dose again or eliminate the oral contraceptive and see if her headaches go away, rather than embarking on an expensive evaluation, because very commonly oral contraceptives will provoke or trigger migraines. Caffeine, alcohol, some other factors. Sometimes when people are very hungry, it'll trigger a migraine. Certain foods in certain individuals, chocolate, for instance, in some people, they know will trigger a attack, as well as alcohol and caffeine. The classic migraine, as we said, is preceded by the visual or sensory symptoms. Doesn't really distinguish how you'll treat that patient, other than it gives you the benefit, the advantage of knowing that the migraine is about to come, and so you could start your treatment before that migraine is well entrenched. Okay? For a migraine, what are you going to do? Obviously, you're going to discontinue any exacerbating factors, which we just mentioned. You're going to think about prophylactic treatment. And by prophylactic treatment, we don't mean putting her back on oral contraceptives. We're not talking about that kind of prophylaxis. We're talking about headache prophylaxis, whereby someone who has frequent headaches, migraines, should be on some medication to reduce the likelihood of developing headaches, of the migraines. And those are either beta blockers or calcium channel blockers. The exact etiology of migraines is not known, but it's thought that the pathophysiology has to do with increased vasomotor tone, increased vasospasm. And calcium channel blockers and beta blockers alter this vasomotor tone in a way that reduces the frequency of migraines. That's what we put in the category of preventive or prophylactic treatment for migraines. Abortive treatment refers to someone who's just had their aura and knows they're going to get the headache, or someone with migraine, common migraine, who feels their typical migraine coming on and wants to cut it in its tracks. There, the drugs like sumatriptan, which are now available as oral medication, formerly just available as injectable medications, are very effective. It's still useful to have the injectable medication because that other associated symptom we talked about in migraine, which is nausea and vomiting. People having a lot of nausea and vomiting are not going to keep down their triptan pill, and then you'll give them an injectable dose of sumatriptan. And that would be a way to gain points or lose points on CCS. Let's say they give you a straightforward history of migraine, and the question is going to be all about how to manage that patient. And they tell you the patient has a lot of nausea and vomiting. And you say, okay, they got their aura just now. What do you do next? Sumatriptan, or any of the newer triptans that end in triptan. Okay? They're serotonin inhibitors. What will you do in that patient? You'll say sumatriptan. Then the question will say, by what route? And they'll have told you it's nausea and vomiting. Don't write oral. Write intravenous. Once that headache is well entrenched, what could you do? Well, triptans still have a role once the headache is there and ongoing. It might not be enough, and some of these patients will require stronger analgesics, even including opiates, to control these very fierce migraine headaches. So think about it in terms of avoiding exacerbating factors, thinking about, in the patient who has frequent attacks, what prophylactic medication, beta blockers or calcium channel blockers, the triptans or ergotamines, which is, ergotamine is caffeine, is a form of an ergotamine in the same family. Those are also effective as abortive treatment, but the triptans, unlike the ergotamines, the triptans are also effective in the protracted symptoms once the headache is there, and you might even need to use things as strong as opiates. Sometimes we use combinations of barbiturates and aspirin. Butalbital is a medication that's a combination of a barbiturate and aspirin. And this is the different phases of migraine management. Now, we mentioned in the differential that could this be another kind of headache? Well, it can be. And we should therefore take this opportunity to discuss some of the other primary headache symptoms. By primary headache, I mean the headache is the primary problem, as opposed to subarachnoid hemorrhage or a brain tumor where the headache is secondary to something else. And again, thank God, fortunately, for every patient you'll see with a subarachnoid hemorrhage, you'll see 1,000 patients with tension headaches and 250 patients with migraine headaches. Right? The primary headaches of tension headache of migraine are extraordinarily common and responsible for a huge number of health visits every year. How do you distinguish tension headaches? How do you make the diagnosis? It's really a diagnosis you make on the portion of the question that gives you the history. It's going to be chronic. It's usually bilateral, uncommon to be unilateral tension headache. It's that constricting feeling, often related to stress, not always, but very often patients will tell you, oh, I had a terrible day at work and my head is pounding. All right? It's not something that they necessarily wake up with. As the day goes on, as you're sitting in class watching tape after tape, you got this wicked tension headache. And so that throbbing nature. The treatment for that, NSAIDs. All right? We don't really talk about prophylactic treatment for tension headaches. We don't talk about abortive treatments, although patients who feel a tension headache coming on know what's coming, and they'll go and reach for their NSAIDs. All right? Aspirin, ibuprofen, etc. That's probably the most common, not probably, that is the most common cause of a primary headache. The other one that you need to know about in terms of primary headache families is the cluster headache. And by cluster, we mean they're clustered together in time. Patient might be very well for a number of months. Then they have a period of several months where these headaches are clustered together time-wise. It usually takes a patient from being asymptomatic and peaks fairly quickly. A tension headache might take some time to build. The cluster headache, within 15 minutes, it's at its peak. And it doesn't last for very long. It might last only about an hour or two and has a very characteristic presentation on the board. It's not going to be confusing to distinguish between migraine and cluster and tension, because the cluster headache, they will definitely give you signs of unilateral problems. Now, migraine, you said, might be unilateral, throbbing. A cluster headache, they're going to give you other symptoms, either eye symptoms with unilateral lacrimation, tearing of the eye. The pain is often behind the eye most severe, as opposed to this area in the migraine. And there's often nasal symptoms as well, nasal stuffiness, congestion. Patients might even have symptoms of meiosis unilaterally. That is pathognomonic, that unilateral combination of findings for a patient with cluster headache. The treatment here is different. The treatment here is not with the ergotamines. It's not with the NSAIDs, although they're used as supplements. It's not with the triptans, although those are also used. The primary treatment for these headaches, which can be very severe, is prednisone. Short courses of prednisone, and then you get the patient off. And again, there's long periods where they're asymptomatic. And this headache family is characterized by a gender difference in terms of this headache is more common in men than in women. And we'll take a break here.